Hello guys, I welcome all of you to today's Pharmcast. I'm Dr. Ranjan, your pharmacology faculty at Marrow. And we are towards the last end of Pharmcast, One Touch Pharmcast, which is based upon the One Touch Pharmacology book. Today guys, I'll be covering two topics, blood and GIT, both are small topics. And today I have already posted the schedule for this week, how you're going to revise it. After this, we are left with only one Pharmcast, that is covering topics like respiratory system, autocoils, etc., which I'll try to post today or tomorrow. So I have speed up with this Pharmcast, and I'm trying to post them as soon as possible because the exams are nearing, right? So let's begin with blood, guys. Page number 71. Anticoagulants we can broadly subclassify into oral and parenteral. And today we have two classes of oral anticoagulants, as you can see on the left hand side. These are the DOAC or NOAC and warfarin, right? Now, DOAC or NOAC, the first MCQ points here which have been asked is based upon the name of the drugs, like which is an oral direct thrombin inhibitor, that is dabigatran, or which is an oral 10A inhibitor, apixaban, rivaroxaban, edoxaban, right? These are oral 10 inhibitors. So the first MCQs here which have been asked in the last 5 to 10 years, these are pretty basic ones, right? Now, upon the uses of these drugs, remember they do ask you what is the drug of choice for prophylaxis or treatment of DVT, deep vein thrombosis. In that case, now your answer would be a DOAC. DOAC is the preferred drug, but it is not commonly asked. DVT is not commonly asked. In the last 5 years, if you see, there's the second point. What is the drug of choice for prophylaxis of thrombosis in non-valvular atrial fibrillation? If this is asked, non-valvular means when you have your own valve, native valve. And there is another case where we have the mechanical valve. So when I'm not having a mechanical valve, I'm having my own valve and I'm having atrial fibrillation, then to prevent thrombosis, my preferred drugs, my go-to drugs are DOAC or NOAC. The exceptions are if there is severe mitral stenosis. In that case, I go for warfarin. If there is renal failure, then I go for warfarin. And these are the cases where I prefer warfarin. And the third one is obvious that whenever I have a mechanical valve, I go for warfarin. So this is easier to remember. So for example, like see, where would I prefer warfarin to prevent thrombosis, right? In atrial fibrillation. So just reverse M, just reverse W. Warfarin starts with W, isn't it? So just reverse W and what you get is M. So M means mechanical valve, M means mitral stenosis, severe mitral stenosis. Severe is one word we need to add. And third one is renal failure. In that case, I go for warfarin. Otherwise, I'll go for DOAC. Now, in case of these, antidotes are commonly asked. So what is the antidote of dabigatran? Idarosizumab. What is the antidote of oral 10A inhibitors? Andaxanet alpha. These are, guys, highly, important drugs which will be asked in your exams. Now, coming to warfarin. Warfarin has a lot of MCQs over the years, you can see, right? Number one is a simple one. They had asked you dicomarol. So, warfarin or dicomarol, it acts by, antagonizing vitamin K. And another MCQ they had asked you, warfarin, what is the type of block cause to vitamin K? Is it competitive or non-competitive? Remember, vitamin K inhibition by warfarin is competitive inhibition. Second MCQ which has been asked always, guys, in the not only in 5 to 10 years, even in the last 20 years, this MCQ has been asked. Which are the coagulation factors affected by warfarin? And these are vitamin K dependent factors, that is 2, 7, 9, 10. And they do ask which is the first factor to decline. So remember, the first factor to decline is factor 7, followed by protein C and S. The last factor to decline is factor 2. So these are the MCQs they ask. Uses. It is drug of choice for prophylaxis in thrombosis. Warfarin, I have told you, in case of mechanical valve. So I'll reverse W into M, mechanical valve, plus M for mitral stenosis, which is severe, plus third one, whenever there is renal failure. My go-to drug has to be warfarin. Now, side effect of warfarin, guys, it can cause skin necrosis. That is one MCQ. Second, they ask you which is the most common side. It is limbs. Third, what is the cause of skin necrosis? It is due to decrease in protein C, a rapid decline in protein C, because protein C is an anticoagulant protein. So a rapid decline can cause, it is teratogenic, that's an MCQ. Plus it can cause purple toe. This is the most recent MCQ that was asked last year. Now, what is purple toe? Is bilateral painful purple discoloration of toes, and that is due to cholesterol embolization. So, image was given, and in case here, see, if there is a toxicity to warfarin and there is bleeding, what would I be using for treatment? The antidote is prothrombin complex. Now, coming to the second half, in page number 71 in One Touch Pharmacology book, parenteral anticoagulants. See, parenteral DTI or direct thrombin inhibitors, there is only one MCQ point. What is the drug of choice for HIT or heparin-induced thrombocytopenia? It is argatroban. Indirect thrombin inhibitors, UFH, LMWH, fondaparinux. Your first MCQs are which factors they act upon. UFH, factor 10 and factor 2. LMWH, factor 10 more than factor 2. Fondaparinux, only factor 10. Your first MCQ point, right? UFH uses are not that asked. Your second MCQ where they ask MCQ is UFH antidote, that is protamine sulfate. So I've covered that in red. And side effects and contraindication, though they are not that commonly asked, but these are MCQ points, and you can see the mnemonic that I've given, a hot teacher. So you can remember at least few side effects and contraindication from this. Whereas LMWH and fondaparinux, these are preferred for treatment of DVT treatment, they're preferred. And the most recent MCQ was what is the route of administration of LMWH and DVT? And our answer was subcutaneous. So the route is asked, subcutaneous. The last thing here in coagulation, see, they ask you for which drugs coagulation monitoring is not required. There are three classes, DOAC, LMWH, fondaparinux. Wherever coagulation monitoring is required, they ask, what do I monitor? So in case of parenteral, all the parenteral DTI and ITI, I monitor APTT. Warfarin, I monitor PTINR. Now moving on to page number 72 in One Touch Pharmacology book, anti-aggregants. Let me simplify this. Anti-aggregants, most of the MCQs in these years have been on the mechanism of action. So they ask you aspirin blocks what? Cyclooxygenase 1. Right? Clopidogrel blocks what? P2Y12 receptor. Right? Abciximab, tirofib and aptifevatide, they block what? GP2B3A in proteins. So this is basically the most commonly asked MCQ. Then I'll tell you a couple of MCQs which have been asked. With respect to clopidogrel, they ask you which gene polymorphism can decrease its effect. Your answer was CYP2C19. Third MCQ that asked you with respect to clopidogrel is, along with which drug it should not be given because that drug can decrease the effect of clopidogrel, and for that your answer is omeprazole, right? Prasugrel, there is one MCQ that asked you which is not supposed to give in cerebrovascular disorder like stroke and TIA, transient ischemic attack. Your answer is prasugrel because it increases the risk of intracranial bleed. So these are all the MCQs that have been asked throughout the years. Now moving on to fibrinolytics. Streptokinase is not asked nowadays. The reason is not that used commonly nowadays. Most MCQs are concentrated in fibrinolytics or thrombolytics. It is in the section of TPA. TPA analogs. Your first MCQ is on the name. Which of the following is a tissue plasminogen activator analog, or which of the following is a fibrinolytic? Is a very basic MCQ which all of us should be able to answer. Alteplase, reteplase, tenecteplase. Second MCQ they ask you where I don't use it. Now remember, if you look at the uses I've written in the book, it is used in STEMI, but I have not mentioned NSTEMI. So when they ask you which of the following is false regarding alteplase or reteplase, your answer is it is used in NSTEMI is the answer. Third MCQ which has been recently asked 2 years back, what is the antidote of choice for fibrinolytics? Your answer is tranexamic acid. It is more preferred as compared to EACA or epsilon aminocaproic acid. Contraindications, they are not that commonly asked, but remember the mnemonic I have given you, brain and those contraindications. The last topic in blood, it is hematopoietic agents. Right? These are not that commonly asked, but I'll tell you 3 to 4 points which they ask as MCQs. Number 1, they ask you what is the drug of choice for anemia in a patient of chronic renal failure, and your answer is darbepoetin or epoetin. Darbepoetin is more preferred because it is longer acting, right? Then they ask you which of the following is a GCSF analog. Your answer is either filgrastim, lipeg-filgrastim. Then they ask which is GM-CSF analog, then your answer is sargamostim. If they ask which is interleukin 11 analog, it is oprelefkin, used in chemo-induced thrombocytopenia. And if they ask you which is thrombopoietin agonist, your answer is romiplastim or L-thrombopag, used in ITP, or immune thrombocytopenic purpura. So mostly here your MCQs are based upon the name of the drugs or uses. If they ask, it is mostly about CRF causing anemia, and there I prefer erythropoietin analogs. Right guys, we are done with your first topic, that is blood, which is a very important topic. Now I'll come down to the second half for today's Pharmcast. Another topic which is not as important as blood, and that is your topic of GIT, gastrointestinal tract, right? So gastrointestinal tract, we'll have a look at the first topic, that is peptic ulcer disease. And there are three classes of drugs: anti-acid secretory agents, number one. So see, these drugs, they will decrease secretion of acids, and here proton pump inhibitors. Overall, if I say PPI, I mean proton pump inhibitors in peptic ulcer disease. The reason being, they have taken over the business of all other drugs. So most commonly asked drug in case of peptic ulcer disease, these are the anti-acid secretory agents, right? And PPIs. So PPI is your first MCQ is on drug of choice, where their drug of choice, see, anything related to stomach, anything related to stomach, PPIs are the drug of choice. So it can be any kind of ulcer, GERD, Zollinger-Ellison syndrome, Barrett's esophagus, H. pylori. One point you need to remember, there is only one disease where lifelong PPI is required, and that is Barrett's esophagus. The reason being, it's a pre-neoplastic condition, right? So uses are important. Second, they ask you, when should I take PPIs? At least 30 minutes before food. That is the right answer. Side effects of PPIs. Guys, remember, PPIs are important. So PPI side effect: pneumonia, pseudomembranous enterocolitis. They can decrease absorption of calcium, iron, vitamin B12. And because of decreased calcium, they can cause osteoporosis and a specific fracture, that is hip fracture. So these have been asked. They can also cause hypergastremia. H2 blocker. Remember, the only MCQ that is asked nowadays is about the side effect of cimetidine. It can cause impotence and gynecomastia. That is because it can block androgen receptors. It can increase prolactin, and that is the reason why it can cause galactorrhea. Now moving on to the second class of drugs in peptic ulcer disease, these are gastroprotective agents. And guys, remember, gastroprotective agents, misoprostol is a prostaglandin E1 analog. So only MCQ they ask you here, what is PG, prostaglandin E1 analog, misoprostol? Now remember, use of this drug is used in NSAID-induced gastric ulcer, and it is the most specific drug. But if they ask you what is the drug of choice for NSAID-induced gastric ulcer, your answer will not be misoprostol. What would be the answer in that case? The answer in that case would be PPI or proton pump inhibitors. Now sucralfate. Sucralfate, see, remember, is a drug which is a gastroprotective agent, and it is polymerized by gastric hydrochloric acid, right? And that is the reason why, since I need acid, it is contraindicated with antacids. That's a commonly asked MCQ. And it is contraindicated with any other drug. So any other drug should be taken 2 hours before food. This is a recent MCQ that asked you, phenytoin has to be taken how many hours before? Your answer was 120 minutes before or 2 hours. Food is to be taken 1 hour before sucralfate. Antacids are to be taken 30 minutes after sucralfate, after. So remember the before and after, right? Bismuth is not commonly used nowadays. So the MCQ point you got to remember here is the black color stool and tongue. And antacids, see, antacid is the last class of drug here in peptic ulcer disease. The only MCQ they ask you here is antacids, why do I combine both aluminium and magnesium? The reason is aluminium causes constipation and magnesium causes diarrhea. So if you combine each other, they will cancel each other's effect. Other than that, they don't ask much anything. There is nothing much to ask on antacids. Now coming to other classes of drugs like antidiarrheal drugs. See, antidiarrheal drugs like loperamide, they have asked you what is the drug of choice for IBS associated diarrhea. It is loperamide, non-secretory diarrhea, or irinotecan associated diarrhea. If they ask irinotecan, then your answer would be loperamide. Octreotide is the drug of choice for secretory diarrhea. Allosetron is a 5-HT3 blocker that can be used in diarrhea in females in IBS. And the only MCQ that has ever been asked on allosetron is which is a 5-HT3 blocker used for treatment of diarrhea. Your answer was allosetron. It's not ondansetron, palonosetron. Those are antiemetics, right? So these are antidiarrheal drugs. Now prokinetics. Now see, prokinetics are nothing but these are D2 blockers. And the only prokinetic that is asked as an MCQ is metoclopramide, because it is also used as an antiemetic. So whenever I use metoclopramide, it crosses blood-brain barrier and it can cause extrapyramidal side effect like acute dystonia and Parkinsonism. So what are the MCQs they have asked you? acute dystonia causes abnormal posturing. That is something we have discussed in CNS. So if they're asked you, a patient was given antiemetic, he developed abnormal posturing. Which drug he was given? Answer is metoclopramide, right? Second MCQ which has been asked, a patient was given metoclopramide for nausea vomiting and he developed abnormal posturing. Then in that case, they had asked you, what should I use for treatment? So for treatment, I'm going to use drug like benzhexol, which is also known as trihexyphenidyl, or I can use promethazine. So all these three drugs are important which have been asked. 5-HT4 agonist, the only names are important. The only MCQ you can find in the last 5 years is this one. Which of the following is a 5-HT4 agonist? Your answer was procalcipride. Antiemetics, 5-HT3 blockers, these are most important. Ondansetron, it is drug of choice for chemo-induced nausea vomiting. It's a commonly asked MCQ. Other drugs, names are important. Neurokinin 1 antagonist, aprepitant. Cannabinoid receptor agonist, dronabinol, nebilon. Here the side effects are hypotension. And the MCQ once they had asked you for which antiemetic I need to monitor blood pressure. Right, your answer was dronabinol. And all these can be used in chemotherapy-induced nausea vomiting. The last topic in GIT and the last topic for today, this is laxatives. Now see the number one, chloride secretors. These are the most important drugs, lubiprostone and linaclotide. They ask you about mechanism. Lubiprostone stimulates type 2 chloride channels. Linaclotide stimulates guanylate cyclase and thus activates CFTR or cystic fibrosis transmembrane regulator. This is the most important one which both have been asked. Tenapanor, it blocks sodium proton exchanger. Stimulants like bisacodyl, senna, one MCQ they ask you is which laxative causes melanosis coli or black pigmentation of the colon. Your answer is senna, right? And see the maximum use is 10 days because of risk of atonic colon. Osmotic laxative, one they ask upon the name, which is osmotic laxative, mannitol. Second, they ask you which laxative is used in hepatic encephalopathy. Again, your answer is mannitol. Stool softener, again, they ask on name, which is a stool softening agent. Your answer is Docused. There are two salts, Docused sodium and calcium. So guys, if we do this much in blood and GIT, this is our bare minimum to clear the exam. And 90% of your MCQs in blood and GIT would be asked from this section, whatever I have discussed, right guys? So as you know, every day whenever I conclude the Pharmcast, I try to pick up one of your doubts and try to give you a solution to that, some practical solution to that particular doubt, right? So one student had asked me, sir, how many grand tests do I need to give? Before the 5th March exam, right? Now, if I would have been in your place, so whenever you ask a doubt, I keep myself in your position and then I take a decision, right? What I would have done in your place. So, see, there is a month of Fab, a fair amount of time left in Fab. So, what I would have done is I would have given at least 2 grand tests in the month of Fab, and I would have given 1 grand test on the first or the 2nd of March, not very close to the exam, but at least 2 to 3 days before the exam. So why would I give 3 grand tests before this exam? The reason being, see, that solving 200 MCQs in a given period of time, that's also an art. You should be able to cruise through 200 questions without even a drop of sweat, and that needs a lot of practice. So keeping a good practice before the exam is handy, right? And second, I don't have time now. So what would I do regarding revising the GT, right? Now, if I look at revising the GT, I have 2 options. Either I could revise a grand test, using too much of time, or I could just give the GT, just look which one I have done wrong briefly, very fast, within 1 to 2 hours, and be done with it. And then get back to my notes and keep revising and solving a question bank. So I'd be doing the second one. I would not spend too much time in revising GT in these last 1 month, because that can be counterproductive, right? So I would revise it obviously, but I would just look which one I have done wrong, and I would move on. I would just move on and get back to my notes and keep revising. Because remember, at the end of the day, the exams, the MCQs will be new ones, and you need to have a good grasp over your notes. So in this last 1 month, you need to solve questions every day. Solving question has to be an everyday affair. I have to revise my notes. I have to do that. That's also important. Plus, I need to give 2 to 3 grand tests in this last 1 month. And the last GT, 2 to 3 days before the exam, and I would give that GT, the last GT I would give at the same time when the exam is going to happen. So if the exam is from 9 to 12, I'll give the GT from 9 to 12 without any interruption. So the last GT I would give it as if I'm giving the exam. Are you getting my point? So that if I do something wrong in that last GT before the exam, I would not repeat that in the exam. So guys, GT by GT, day by day, our aim is to achieve perfection. We are trying to be as perfect as possible, right guys? So that's all guys for today's Pharmcast. This was Dr. Ranjan, your pharmacology faculty with Marrow, and this was your One Touch Pharmcast. And as days will pass by, things will get difficult and difficult, as if you are moving deep into the ocean and the pressure will keep on rising. So just you are in the same situation. And in this case, the only thing that can be done is you need to make yourself hard. The moment whenever you are down and you think of giving up, you just remind yourself, why did you start this for so many months? You remind yourself, for whom are you doing this? Not only for yourself, because most of us, we belong to middle class, lower middle class families, and our parents, they have a lot of hope. So whatever I've done in my life, my inspiration, they always have been my parents. So I wanted to do something for them. So obviously we do things for ourselves, but you have to go beyond yourselves, right? You have to find that motivation. For whom are you doing? On whose face you want to bring that smile? Whose life are you going to change anyhow by giving some happiness in the form of serotonin, or by giving some materialistic, achievements to your parents in the form of dopamine? So whatever be it, find your inspiration. Keep moving forward. All the best guys. Take care. Lots of love and blessings. Bye-bye.